So we're going to move on now and talk about lung cancer. A lot going on in there, as in every part of oncology. So welcome to our faculty. So we have Dr. Sarah Goldberg from the Yale Cancer Center in New Haven, and Dr. Josh Sabari from the NYU Langone Health and Perlmutter Cancer Center in New York City. So before we get started, a couple of points and actually a question we got sent in about a case. So we just finished up with a World Lung meeting, and just kind of curious. So we had a whole bunch of new data presented. But Sarah, we also had, and I think we're going to show some slides later on, but I just want to kind of get your take, because I think it was one of the most interesting presentations there, of a new bispecific that combines, targets PD-1 as well as VEGF, which has been an issue and a question in lung cancer. Any thoughts about this strategy and about VEGF? You see a re-interest in that?
I think that was a really interesting study. This is the trial of ivonescimab in the first-line setting for metastatic non-small cell lung cancer. They compared ivonescimab with pembrolizumab. And so this, as you mentioned, this is a bispecific antibody against PD-1 and VEGF. The data look really promising. There's a significant progression-free survival benefit with ivonescimab versus pembrolizumab, which has been our standard. I'll talk about that a little later. And so I think this is something definitely to keep an eye on. This was a study done in Asia. It's now being replicated in the US and other countries throughout the world. And I think it's something to watch. It's a really interesting mechanism and really compelling data so far.
So any thoughts about this drug, ivonescimab? Again, we'll take a look at the data, but it beat Pembro in this situation. Now, of course, we don't know. There could have, I guess, theoretically been a third arm of Pembro and Bev. I guess that might be one question. John Haymock did the discussion of that. And do we know much about tolerability issues? I guess you see some, Bev-like hypertension, et cetera, but any other issues, Josh?
It's very interesting compound. I think we've had a lot of failures with VEGF inhibitors and PD-1 inhibitors, right? The IM Power 150, carbotaxol, atezo-bev, not commonly used in clinical practice. So maybe something about the bispecific nature of this therapy causing us to have better activity. What was really interesting, Neil, was that we didn't see significant toxicity. What are some of the toxicities you'd expect with a VEGF inhibitor? You'd expect hypertension, proteinuria, bleeding, right? Hemoptysis. They did exclude those patients from the study who had central tumors. So I agree with Sarah. We really need to see the data replicated here in the United States, but it does look to be an exciting asset.
And so, Sarah, in a second, you're going to talk about non-targeted therapy, and Josh, you'll talk about targeted therapy, although we can't cover everything in both of those topics. There's so much to talk about. But I wanted to ask you, we got a number of cases, including this one from Padmaja, a patient with stage 2 adenocarcinoma on lung treated in neoadjuvant chemo IO with Nivo, 3 cycles. Patient had a complete pathologic response. What would you do about post-op therapy? She wants to know, would it be different if the patient had a partial response? And of course, I think the question everybody has right now with the data exploding, I'm going to show some of the slides between your two talks, like when do you use neoadjuvant therapy and how?
This is such an evolving area in lung cancer treatment right now. How do we select patients for neoadjuvant chemoimmune therapy? Which patient should go for upfront surgery? We don't have good randomized data to say which strategy is better, neoadjuvant or adjuvant. I think increasingly we are using neoadjuvant therapy. There is really strong data for neoadjuvant chemo plus immune therapy, different immune therapies, nivolumab, pembrolizumab. And so I think this is becoming much more of a common strategy. The question that was initially asked about when you use chemoimmune therapy as neoadjuvant therapy, and then the patient has a complete pathologic response, those patients do quite well. Most of those patients, as we've seen so far in the trials, many of them won't relapse. And so there's this question of, do you need the adjuvant therapy component? Again, that hasn't been tested in a randomized study, so we don't really know the answer in a prospective fashion. I think many people will consider omitting the adjuvant therapy with a path CR, but we really don't have prospective data to guide us, so it should at least be considered.
So can you maybe, Sarah, give an example of a patient where you would definitely think about neoadjuvant therapy and a patient you definitely send to surgery?
I think the stage 3 patients are a bit easier in my mind to really strongly consider upfront chemoimmune therapy. We've known for many years that upfront surgery for someone with mediastinal lymph node involvement probably should get some neoadjuvant therapy of some sort. And so I think those patients, the stage 3 patients, mediastinal lymph node involvement, they are doing extremely well with neoadjuvant treatment. The stage 2s, I think that's much more of a debate that we have in our tumor board, where some of those, just for lymph node negative tumors, maybe we might consider upfront surgery. But I think even in the stage 2s, there's compelling data, and I think that could be considered. So those are the ones where we have a lot of discussion, upfront surgery versus neoadjuvant therapy.
So Josh, same question. Also, does PD-1 level make a difference? And of course, the question we ask all the time, does cell-free DNA have any future in this situation?
Yes, I think PD-L1 expression does matter, but before you look at any of the biomarkers, I agree with Sarah, you have to look at the stage of the disease. So, if you have a patient with N1 disease, but a very small tumor, that patient has a high risk of recurrence versus a T4, large tumor, no nodal involvement, that's also a stage 3, a 3A patient. That patient may have less of a risk of recurrence. So, at our center, anyone with N1 disease or high-risk features, we're going to recommend neoadjuvant therapy. And, PD-L1 expression matters to us, but we're giving everyone chemo and IO. So I don't think we flesh that out in the early stage setting. You talk about liquid biopsy or MRD assays. I think they're important up front to define what the driver mutation is for that patient. So if someone was EGFR or ALK or other, actionable alteration, I would not give chemo IO in that patient population. But on the back end, post-completion of therapy and surgery, I'm not sure we have great data yet to use these assays in monitoring how we give patients further therapy.
So Sarah, in a second, you're going to go through a lot of data on non-targeted therapy, particularly immunotherapy. We had an interesting question sent in about a patient who had no targetable mutations on tissue biopsy and wondered, is there a point in do you ever see liquid positivity with tissue negative? What about non-smokers? What about RNA assays? Any thoughts?
In patients with advanced non-small cell lung cancer, I think there's absolutely a role for tissue and liquid biopsies. I think you really want to know the mutation status of those patients, ideally before selecting first-line treatment. So often in my institution and many others, the tumor biopsy is sent for molecular testing, so I may have those results back. If it shows something targetable, I go with that. I don't necessarily feel like I need the liquid assay. If it doesn't show something targetable, I probably will send the ctDNA analysis, because you occasionally can find something in the blood that for whatever reason was not found in the tumor. So they are complementary, and sometimes one picks up something the other doesn't. So I really want to know the mutation status of my patients with non-small cell lung cancer, and so I'll use both as needed.
What about, for example, a non-smoker? Where does RNA come in? Or most assays now, including an RNA assay, do you have to order it separately?
So the non-smoking patients with non-small cell lung cancer, usually adenocarcinoma, they tend to have a higher propensity for having these mutations, but I don't use smoking status to make my decisions about this. I think if a patient has metastatic, non-squamous, non-small cell lung cancer, I'm working hard to find out what mutations they have. I don't use smoking status to make my decision about how hard to look. The RNA is also important. A lot of these kind of broad molecular tests, the NGS tests, do include RNA assays as part of them, because they're looking for fusions and other alterations that are harder to find on the DNA level. So a lot of the assays include both DNA and RNA.
Josh?
Yeah, I agree. I think especially if you have a patient who have a high pretest probability for a driver alteration and you didn't identify one in your panel, right, with a DNA-based panel, you should reflex to an RNA-based assay. Exactly to the point Sarah made, you're specifically looking for some fusions, and we oftentimes can miss those on DNA-based assays. So I think having that high pretest probability, but I agree with you, every patient with non-small cell lung cancer, I'll include squamous, should be sequenced. We identify 1 to 2% of those patients to have an EGFR mutation.
All right, Sarah, let's take a look at some data.
Absolutely. So as you mentioned, Neil, we have had so much exciting data in the realm of lung cancer in the last, really even in the last year. I'm going to go through the non-targeted therapy, and then Josh is going to talk about targeted therapies. So here's the agenda for my talk. We're going to first talk about advanced non-small cell lung cancer. We'll talk about a lot of the studies you all probably know very well now of immune therapy as first-line treatment, whether it's alone or in combination. But we'll dig in a little more detail on the long-term data. How are these patients doing, up to 5 years out and longer? Then we're going to talk about some newer agents. We'll talk about patients with previously treated non-small cell lung cancer, talk about ADCs, as well as some new bispecific immune therapies. And then we'll turn to small cell, limited stage, looking at Adriatic and a few really exciting drugs in the extensive stage setting. So these are studies that, again, I'm sure you all know quite well by now. They're several years old. These are studies that are looking at patients with advanced or metastatic non-small cell lung cancer with high PD-L1 expression. Typically, in the assays used in common practice, it's considered PD-L1 of 50% or greater are the high PD-L1 expressors. And these 3 studies looked at those patients with high PD-L1 expression and randomized patients to single-agent immune therapy versus chemotherapy. Again, these are several years old when chemotherapy was a reasonable first-line option for metastatic lung cancer. And all 3 of these studies, whether it was with pembrolizumab, atezolizumab, or cemiplimab, showed an overall survival benefit with the use of a PD-1 or PD-L1 inhibitor compared to chemotherapy. And this has become very much part of our standard of care to treat patients with single-agent immune therapy who have high PD-L1 expression. There are some caveats here. We probably don't have time to go into all the details and nuances, but I will just say that these drugs, although they have an overall survival benefit and some patients are living for years with metastatic disease, the response rates are not as high as I think any of us would hope, more like around 50%. So we really have to be careful when selecting patients for a single-agent strategy, because if someone is very symptomatic or has high tumor burden, you really want to make sure you're getting a response. What about combinations? So I showed you the single agent data. Well, we of course have many combinations with immune therapy in non-small cell lung cancer. Keynote 189 was probably the first study that really showed us that adding immune therapy to chemotherapy in the first line setting was beneficial. This was for non-squamous non-small cell lung cancer, and you can see this, I think, really impressive overall survival benefit with the addition of pembrolizumab. There was also a complementary study in squamous non-small cell lung cancer, again showing the benefit of adding pembro to chemo. Since then, there's been additional studies for metastatic disease, phase 3 studies. The Empower Lung 3 study looked at cemiplimab with chemotherapy versus chemo alone. And then, as Josh mentioned earlier, Empower 150 was atezo and chemo plus bev, so a bit of a different combination there. You're including the VEGF inhibitor. All of these studies were positive for overall survival, so we're seeing benefit regardless of the regimen used. The addition of bevacizumab, the benefit there is questionable. It's not something that's used commonly in clinical practice, but it's an option. What about chemo-free regimens for the first-line setting? Well, just like in melanoma, we have ipi/nivo as an option for our patients based on the Checkmate 227 data. This was looked at both in patients with PD-L1 greater than or equal to 1% and in a separate cohort, PD-L1 less than 1%. Both of these were positive. The way that the study was designed in the statistical analysis led to the FDA approval of this regimen for PD-L1 1% or greater, although if you can see here on the right, the PD-L1 less than 1% patients actually did have quite an impressive benefit. These are the patients that you don't expect to do all that well long-term with immune therapy, but here they do seem to be.
Quick question to Josh. How do you approach PD-1 negative disease, metastatic disease, first line?
Yeah, this is tough. I think it depends on squamous versus non-squam, but I definitely am thinking about potentially escalating therapy, especially if they have high-risk features genomically, STK11, KEAP1. I think it's an ongoing discussion. We have prospective trials looking at answering this exact question.
What specific therapy do you use, though?
Yeah, I would think about using ipilimumab, nivolumab, and chemotherapy in a high-risk patient who's fit, who's young, PD-L1 0, maybe also has that STK11, KEAP1 alteration that we worry about. Again, no prospective data yet to support that. Lots of retrospective data, including a paper in Nature just about 2 weeks ago.
Please continue.
So these are the studies that you were just mentioning, Josh, the studies that looked at ipi/nivo plus chemotherapy, so kind of the kitchen sink approach where you're adding all drugs. If you look back at the ipi/nivo alone data, this is what I just showed you. At the very beginning of that curve on the left, you can see the curves cross. Some of those patients are doing pretty poorly up front. They're having pretty rapid progression. So that's the idea of giving a few cycles of chemotherapy, trying to get patients past that upfront drop-off. And so both of these studies, either combining ipi/nivo with 2 cycles of chemo or durvalumab and tremelimumab and 4 cycles of chemo, both of these were positive studies for overall survival. So again, I agree with what Josh said. I think these are options for patients, but again, a lot of caution with these regimens. I'm showing you here some of the subset analyses. One point here is the PD-L1 negatives did seem to benefit from these regimens versus chemo alone, but the patients who are older than 75 did not clearly benefit. And I think this really is a caution in terms of toxicity, elderly patients, frail patients. This can be a tough regimen. What about long-term? Basically the same studies I just showed you, but trying to now get at, well, how are these patients doing 5 years out and even longer. We have a lot of data now over the years. And this is something that I find helpful when talking to patients and even talking to referring providers and primary care doctors. What can we expect in these patients? Well, many of these studies, really all of these studies, do have this tail of the curve. I'm showing you data for pembrolizumab and cemiplimab, and you can see even 5 years out with PD-L1 high, single agent immune therapy, about a third of patients, about 30% of patients are having long-term survival. Same with KEYNOTE-189, chemoimmune therapy. About 10% or 20% of patients are having long-term survival. It differs based on PD-L1, and this is really where I think it's important to think about the PD-L1 negatives. So a lot of times we're using chemo-pembro as our first-line treatment for PD-L1 anything, even less than 1%. But you could see on the bottom right there, a lot of these patients are progressing, and the long-term survival in the less than 1% patients is fairly low.
Question to Josh. Do you think we're curing metastatic lung cancer nowadays, particularly with immunotherapy, particularly in these high PD-1 situations? What do you say to your patients?
Yeah, it's $1 billion question. I think a third of our patients are alive and well at 5 years, and for me, that seems like a cure. I think we better have to understand which populations are in that group. I have patients that are PD-L1 100% who progress at 6 months, a year, so we still don't understand who is curable and who is not. So I don't love using the word cure, but I think there's a lot of hope for patients in the current era of IO.
Sarah, what about duration of immunotherapy? Any role for ctDNA? And how do you decide when to stop or if to stop?
This is also not a clearly answered question from the data. The studies with, a lot of these first-line studies did use, especially the pembro studies, use 2 years as the cutoff for duration of therapy. And so now we have data on how patients did once they reached the 2 years. And actually many of those patients have an ongoing response. And so I think typically we will consider talking to patients about stopping immune therapy at 2 years. If my patients had any toxicity, I recommend stopping. If they're doing great, I might consider continuing, but I think 2 years is usually the cutoff where we'll consider stopping.
Cell-free DNA?
Right, and cell-free DNA. So I'm hoping in the near future this will be part of the decision process, but I think as of now, I don't know how to use cell-free DNA to make that decision, so I don't typically use it.
Josh?
Yeah, I actually get a PET here at 2 years. I oftentimes fight with the insurance. They're like, why are you getting this PET? Well, I want to know if there's anything avid there. I get a PET. I also do a ctDNA assay. Oftentimes gets rejected by their coverage. But if those are both negative, to me, I feel very comfortable and confident stopping. Again, a lot of patients feel very attached to their immunotherapy. Those are hard discussions in the clinic.
All right, let's continue.
So again, just showing the long-term outcomes where with Ipi/Nivo, whether it's patients who have PD-L1 greater than or equal to 1% or less than 1%, we have a tail here of the curve. You can see in the blue lines, those are the Ipi/Nivo patients. Again, about 20 to 25% of these patients will be alive and doing well at 5 years. Same with 9LA. I won't belabor the point. So moving on, so we talked all about immune therapy and that many of these patients will have long-term benefit and survival. But of course, most of these patients do relapse and need second-line treatments and beyond. So there's actually some really exciting data, I think, where we can start to see maybe some benefit of some newer agents. So datopotamab deruxtecan is a TROP2 antibody drug conjugate that's now being studied in many different settings. And this is the TROP-ION Lung-01 trial is a randomized phase 3 trial in the second-line setting, comparing Dato-DXd versus our standard second-line treatment, docetaxel. You can see the study design there, randomized 1-to-1 to 6 milligrams per kilogram every 3 weeks of Dato-DXd versus standard docetaxel. On the bottom left, you can see the progression-free survival. This was dual primary endpoints of PFS and OS, and this was a positive study for PFS, so there was a benefit to Dato-DXd over docetaxel, which just warms my heart because we always are trying to beat docetaxel in clinical trials, and this one seemed to do so, although you can see that the median PFS, I would say the benefit is somewhat marginal, and then OS here was negative. So how can we figure out which patients are benefiting? Clearly, some patients are benefiting from Dato-DXd with lung cancer. Well, maybe on the left, you could see with the histology. So maybe it's histology-based. On the top left are the non-squamous non-small cell lung cancer patients, and these are the patients that do seem to be benefiting, whereas those curves are flipped in squamous. There doesn't seem to be benefit and maybe even detriment with Dato-DXd. And then on the right, very quickly, I'll just show you this, I think, pretty exciting new assay. It's a TROP2 assay with a kind of a novel way of quantifying TROP2 on the membrane of the cancer cells. And on the bottom right, you can see for progression-free survival, it was the patients who had high TROP2 levels using this assay that really seemed to have the most benefit. So maybe between histology and biomarker, we can really get at patients who are most likely to benefit.
Do you see this agent, coming ahead of docetaxel? People aren't too crazy about using docetaxel. What about tolerability clinically between the two?
Yeah, so I agree. Nobody's too crazy about using docetaxel. The durability is very short, so even when you get a response, it tends to be short-lived, and toxicity with docetaxel is tough. This agent also tends to be tough in some ways with toxicity. It's still a chemotherapy, right? So you can get similar chemo side effects. You can get cytopenias, nausea, GI side effects, mucositis can occur. So it can be also difficult, just like docetaxel, but I think if we have more efficacy, and as we're using more of these ADCs, our ability to adjust and overcome these toxicities gets better, I think we are, I think we can consider this for second line when we have it available. It's not yet available commercially.
How about this new agent to maybe overcome resistance?
Right, so this is, I think, where there's so many clinical trials in this space, looking at patients who have progressed on PD-1 or PD-L1 inhibitors in the first-line setting, and can we overcome resistance using additional immune therapies? Can we use the immune system in some other way? So this drug, acasunlimab, is a bispecific antibody. It targets, and there's actually a typo there, it's not PD-L4, it's PD-L1. So it targets both PD-L1 and 4-1BB. And so the idea here is that when the drug binds both targets, there's conditional activation of 4-1BB that's dependent on binding of PD-L1. And 4-1BB is a molecule that's on the surface of both T cells and NK cells, and this is an important molecule in terms of T cell and NK cell activation. So this is a phase 2 trial, and they looked at acasunlimab as a single agent, as well as in combination at pembrolizumab, and they looked at different doses. And you can see on the bottom, in terms of overall survival, it was the combination with pembro at the Q6-week dosing of acasunlimab that patients seem to do the best. You can see the 6-month PFS rate is 34%, 12-month is 69%, and some of these patients are responding. Response rate about a third of patients, 20 to 30% of patients. So I think this is a promising agent. There's other ones that are also in clinical trials, and some of these are being explored further in phase 2 studies, and a couple of them are now moving into phase 3. And so this is one to keep an eye on. Moving on to small cell. So luckily, we've seen some great data in small cell recently and have some recent approvals. So Adriatic, this was a trial that was presented at the plenary at ASCO this year and had a standing ovation, which is always fantastic to see for lung cancer. So this is a study of consolidation durvalumab for limited stage small cell lung cancer. It was a phase 3 randomized trial. Patients with limited stage small cells, so between stage 1 and 3, were randomized to either durvalumab, as we know well from the Pacific trial from non-small cell lung cancer, versus placebo. There was also an arm for durvalumab and tremelimumab, which I'm not going to go through here. We don't have data for that yet. And it was for patients who completed chemoradiation. So again, similar to the Pacific trial, after chemoradiation, getting durvalumab versus placebo. And here there were dual primary endpoints of OS and PFS. Here's some of the baseline characteristics just to show you who was in this trial. Most of the patients did have stage 3 disease, so as we are used to seeing in the clinic for patients with small cell lung cancer having stage 3. I think it was about half and half of patients who got cisplatin versus carboplatin plus etoposide with their radiation. And most patients got daily radiation, but some did get twice daily radiation, as is used in some parts of the world. And these were the results that got the standing ovation. So you can see both progression-free as well as overall survival were both very positive for this trial. And so this has now, I think, become the standard of care, except that I don't believe it's yet received FDA approval. But besides that, I think for all practical purposes, this is something that we, even before approval, I think should be considered for patients with limited stage small cell lung cancer. So what about extensive stage? So as we all know, most patients with small cell lung cancer are diagnosed with extensive stage or even with early stage will relapse. And we are always looking for better drugs in the second-line setting and beyond. So tarlatamab is a really, I think, novel and exciting drug that we now do have approval by the FDA for. It's a bispecific T-cell engager, so not something that we who treat lung cancer are so familiar with using. It's the first one in class for lung cancer that was approved. It's a bispecific T-cell engager that binds both DLL3, which is very commonly found in small cell lung cancer, and also binds to CD3 on T cells. And the idea is to bring the two together, the tumor cells, the T cells, and induce T cell proliferation and tumor cell lysis. So the phase 2 Delphi 301 trial is a study of tarlatamab for patients with previously treated extensive stage small cell lung cancer. Most of these patients had multiple, or at least one, but many had multiple prior lines of therapy, so heavily pretreated. Some of them responded to initial therapy and others had short-lived responses. Many of these patients did respond. So you can see that the response rate is somewhere between 30 and 40% for tarlatamab, which is just incredibly exciting for these patients with refractory small cell lung cancer. And then if you look at the long-term or the longer-term outcomes, the PFS as well as OS, we are seeing, I think, pretty impressive results where some of these patients are having long-term PFS as well as OS. Even looking out up to a year in relapsed small cell is something to take note of. This study looked at 2 different doses, 10 milligrams as well as 100 milligrams, and it was the 10 milligrams that moved forward. And as I mentioned, the FDA has granted approval as of May 2024. I think the trick for many of us now is to figure out how to use this in clinical practice, because it can be a tough drug and different than a lot of our other drugs because it typically requires hospitalization. So I did just want to very briefly touch on the toxicity, because this is somewhat unique if you're not used to using these types of agents. It's very common that we see cytokine release syndrome with tarlatamab. Probably about half of the patients will have CRS. Most patients have low grade, but there can be high grade CRS, and that's why we typically admit these patients. ICANS is also something that we see with tarlatamab, although at much lower rates, somewhere between 5 and 10%, but something to absolutely be aware of. Any neurologic symptoms should have a low threshold to bring those patients in, evaluate them, and treat.
Yeah, when I first heard about this, because of course we're going to be talking about the CD3 bispecific in the next 2 modules on lymphoma and myeloma, and I've been saying to them, I'm really curious how the lung cancer people are going to deal with CRS and ICANS. Incidentally, I don't know about you, but my brain is getting, I don't know if you're all talking too fast or what. We actually we had a doc who emailed us and said, we listen to your stuff on the way to work and the way home, double time. I'm like, really? I can barely keep up when they talk normal time. Anyhow, Josh, any experience yet with tarlatamab? And I envision somebody, small cell, COPD, and sick as hell, having CRS. How does that play out?
Yeah, so Sally Lau is the PI at our site at NYU for this drug. So we have a lot of experience, and I've also used it, off study. It's a really interesting medicine. It's a medicine that you have to select your patient population well. So, this is not the therapy to give a patient who's, 85 in a wheelchair, smoking, right? I think you have other options that may be easier to give in the clinic that may be better tolerated. But if you have a fit patient, I had a nurse in her 70s who was very active, and she was very motivated and got this therapy and did well, had CRS in the hospital, but recovered and is doing well about 6 months out now. So, you have to think about what patient population to utilize these therapies. But I think this drug could be a practice-changing therapy for our patients long-term.
Anything you want to hear the subsequent people talk about in terms of management, and any experience specifically with ICANS, and how does that play out in these patients?
Yeah, I think really getting a good baseline sort of understanding of your patient, but also having support, telling family members, look, your mother, your father may become somewhat confused. This nurse that I was telling you about, couldn't figure out how to get home one day, right? So these are real symptoms. So having that close connection, making sure that you have a nurse, a team that's able to contact the patients, and steroids have been very effective in my practice in managing these toxicities. So I think this is a drug that can be given, but needs to be given with close monitoring of patients.
And you want to add to that, Sarah, and also as being discussed again in hematologic cancers, you see it moving up.
I completely agree with Josh that this requires very careful patient selection, both for fitness. You have to imagine this patient's going to become hypotensive, need lots of fluids, and go to the ICU, but also reliability. So if a patient can't report, doesn't have family around who will report, it really is just not safe to do.
All right, well, ADCs, we've been looking for them in small cell.
Yes,
maybe we got one.
We do. We actually might have a couple. I'm going to talk about this one now, but I would say in general, antibody drug conjugates are looking really promising for small cell lung cancer. A bit of a surprise to me, but very pleasant one. So this drug, ifinatamab deruxtecan, or IDXD, is another antibody drug conjugate. This one targets B7H3 and has a topoisomerase 1 payload. There was a phase 2 study that looked at this drug at 2 different doses in patients with relapsed small cell lung cancer. They looked at 8 milligrams and 12 milligrams, and the primary endpoint here was overall response rate. Just very briefly, the patient demographics, these were again, pretty heavily pretreated. Some had just 1 line, but most had 2 or more prior lines of therapy. And this drug does look really promising. So you can see most of those bars on the waterfall plot, regardless of which dose, are going down. So patients are having tumor shrinkage, more at the higher dose of 12 milligrams, where the response rate was in the 50s, which is pretty impressive for small cell lung cancer. Progression-free survival and overall survival also look promising. These are not, what you can see here, probably not giving these long-term responses that we're seeing with immune therapy, but I think they do have, it does have activity. Some of the other ADCs also have activity in small cell lung cancer. And so I hope sometime soon we will see a home for ADCs in small cell lung cancer. So here are my conclusions on the non-targeted therapies for lung cancer. I showed you a lot of data looking at immune therapy alone or in combination. Clearly, immune therapy for most of our patients with metastatic lung cancer is standard. Which regimen to choose is really the trick, and we don't have good randomized data between the regimens to help us, and so using the subset analyses and some of these retrospective studies can be helpful. We now know that durvalumab improves both PFS and OS when given after chemoradiation for limited stage small cell and should be considered for patients, and hopefully will receive FDA approval soon. And then we've seen a lot of really interesting novel drugs. We've seen tarlatamab for small cell, bispecific antibodies for non-small cell that look really promising, and then as well as antibody drug conjugates for both non-small cell and small cell. So a lot of really exciting things in the realm of lung cancer.
So before Josh begins on targeted therapy, we have a couple questions from the audience relative to that. We talked initially about neoadjuvant chemoimmunotherapy. I want to just sort of cruise through some of the recent data that we've seen. Josh, maybe starting out with Checkmate 816. I want to go through all these slides with just more 10,000-foot view of the trials that have been looked at, what we have to determine and what we need to determine in the future. What about Checkmate 816?
Yeah, this is the first FDA-approved therapy in the neoadjuvant setting. And again, I think it brings up that question that you have. What do you do if you don't have a complete path response post-op? I think patients did very well on this study. It's a regimen that is commonly used. We now have perioperative therapies as well. So, how do you define, neoadjuvant versus perioperative versus adjuvant? It's getting quite complicated. And I don't know anybody listens to Sarah on double speed, to be honest.
So what about durvalumab? We talked about it, obviously in non-small cell locally advanced. We just talked about it in limited stage small cell. What about in the resectable setting? Any difference, Sarah, compared to what we saw with Nivo?
So the trial that you just showed with nivolumab was just neoadjuvant. So it was 3 cycles of chemo-nivo, surgery, and that was it. So in contrast, the Aegean trial is perioperative. So they gave 4 cycles of chemo plus durvalumab and then adjuvant after surgery for all patients. So this study also looks really good. This is data looking at event-free survival, and patients are having a significant benefit from the addition of durvalumab. I think the big question is, and you asked this earlier, when can we get away with just neoadjuvant therapy and avoid that year of adjuvant? This study doesn't answer that. It's not randomizing patients to receive or not receive adjuvant, but it does look very promising, the perioperative strategy.
What about this newer data we just saw a few weeks ago at ESMO on a different Nivo study, Checkmate 77T, Josh?
Yes, this is also a perioperative, a neoadjuvant study here of nivolumab in this setting. And, we saw this data presented, I think, by Dr. Cascone from MD Anderson quite a few years already now. And, exciting data. But again, I think to the point that Sarah made, we can't define who is the right patient for what regimen currently. And the FDA actually came down very clearly on the Aegean trial saying we need 6-arm randomization to better understand the outcome. So we can't show this data and compare one study to the other. We do need control arms. I'm not sure if pharma's going to do it. I think we're going to have to do it in our cooperative group studies.
So, Sarah, a lot of people think IOs are similar. We just need to see where the data is and follow the data. We haven't talked about neoadjuvant pembro.
This is another trial that I would put in the same category as the last few, another positive trial, phase 3 trial, looking at, in this case, perioperative. So Keynote 671 is similar to Aegean, where patients got neoadjuvant chemo plus the immune therapy, here pembro, surgery, and then adjuvant. And so this, again, was a positive study, and you can see here both for OS and event-free survival, this was positive. And so I think this is a really reasonable regimen to use and could be considered with all of those caveats we just talked about. When do you select neoadjuvant versus adjuvant? How do you decide adjuvant after surgery? But this is a positive study and is another tool for us.
So, Josh, for the patients who don't get neoadjuvant therapy, what about the use of adjuvant IO, for example, starting out with Keynote 091?
Yeah, I mean, if you had to ask what's easier to do, perioperative or neoadjuvant versus adjuvant, it's clearly easier to do the adjuvant, trials or treatments. And we have 2 adjuvant, approvals with atezolizumab and also here with pembrolizumab. And, to be honest, it's better to have 2 shots on goal. It's better to have, sort of that neoadjuvant approach. But you need to get your ducks in a row in order to do that. You need to have that close contact with your thoracic surgeon. I think, honestly, adjuvant therapy is a lot easier, and most patients treated in the community are actually treated just with adjuvant therapy.
So we were talking about ivonescimab that was compared to Pembro at the recent World Lung Meeting, and there it is. It beat Pembro, and I guess the question would be whether or not we could see the same thing with an IO and Bev. I guess we haven't seen much to think that might happen, but that is a theoretical consideration. I think Josh talked a little bit about some of the side effects that have been seen. I think it's also been looked at in patients with EGFR, we're going to talk about in a second, in the relapse setting, looks encouraging. This is a pretty recent development. Just a couple weeks ago, 10 days ago, the approval of tumor treating fields in lung cancer. I was involved a long time ago when this was looked at in glioblastoma. We were going to the SNO meeting, et cetera. Everybody was like, wow, what is this? But here it is. It's now approved. And interestingly, patients who are going to be getting PD-1 inhibitors. Sarah, can you talk a little about your understanding of how this therapy works, or whether you think it works?
I'm not sure that anyone could talk about how it works exactly. I think the idea is, you could see it in this picture right here, that there's this physical device placed on someone's chest where the tumor theoretically is in lung cancer, and it releases these electric fields. How it works is unknown. I think there's a lot of speculation that it has something to do with the immune system, or as you can see here, cell division, but I don't know that we really know. But we have this study, this is from a couple years ago now, that we've seen data that showed that there was a benefit to adding tumor treating fields in non-small cell lung cancer. The problem with this study that makes it a little tricky to figure out what to do, there's a few problems, but I think one of the problems is it started so long ago that it was before we had all these first-line immune therapies. And so these patients had first-line chemo, and then they either received tumor treating fields with second-line immune therapy or with docetaxel. And it really was on the left, you could see the combination with the immune checkpoint inhibitor where there was benefit. The docetaxel arm was negative. And so the problem is we don't use second-line immune therapy as a single agent anymore. So should we use this up front? That's not how it was approved. So it's really unclear how to use it. And then there's the whole physical issue of like wearing this thing for a lot of the day. So I personally don't have experience using it. We didn't have these clinical trials open. But I think there's more trials that are now going on. So we might see more on this in the future. And I think if we can see convincing data that it really improves outcomes in a setting where it makes sense in our current clinical practice, I think it could be considered. But for now, I'm not a user.
So, Josh, any thoughts? For the first time I heard about it, I thought, well, at least they're trying something different.
That's
completely
right.
Different strategy. Doesn't seem to have any serious issues, but a lot of inconvenience. I guess dermatitis from the electrodes. Have you actually had patients that receive it?
Yeah, so I've had patients with mesothelioma use it, and there's a sort of off-label process where you can get that for patients. I've not had lung cancer patients, but we have had GBM patients in our practices treated. I think I agree with you. It's a new modality. I mean, we all feel very comfortable and confident with surgery, radiation, and systemic therapy. This doesn't necessarily fit into that field. Now, I agree with Sarah here that the data is problematic in that it was done a long time ago and it wasn't done in our current patient population. So I don't see anybody IO untreated right now. The correct study is ongoing, the B36 study, where they're combining pembrolizumab and the TTF, the tumor treating fields, in the front line. So I really need to see that data to convince myself to use this, but it is interesting, it's exciting. I think it's a new modality, as you mentioned, and we need new modalities in oncology.
So Josh is going to talk in a second. And here's a study looking at patients with brain mets, where looks like there's some benefit. Where this is going to land, I guess, is interesting, or to be determined moving forward. But again, doesn't seem to have any serious tolerability. There's more. And here's the trial you talked about. This could be one. Of course, by the time this comes back, maybe we'll get a readout on the bispecifics being better than Pembro, but at least it's hard to keep up to date. So before Josh gets into targeted therapy. Just sort of a couple of general questions about targeted therapy. Sarah, of course, we saw another part of the huge lung plenary session that had the Adriatic study. Also was a study looking at locally advanced disease, the LAURA study with osimertinib showing much greater benefit, and now I think being adopted as a standard after chemoradiation. What I want to ask you about it is where else would you like to use it in targeted therapy? If you have a patient who's got RET or CMET, would you like to use it? Have you used it?
So I agree, osimertinib is now our standard. It's actually been my standard and many people's standard for a while after chemoradiation for stage 3 lung cancer. So clearly LAURA was very positive and it's now our standard. Where we extrapolate that data to other targeted therapy or targets and targeted therapies, we don't have data. But I think you can extrapolate, and I tend to at least consider it in my patients. I think ALK and ROS1 are the more obvious ones to at least consider. I think we have data for alectinib for ALK-positive disease in the resected setting, so that's different than after chemoradiation. But if you're extrapolating from LAURA in the post-chemo radiation and extrapolating from ALINA in the post-surgery, I think for ALK, in my mind, you can consider that for patients. Again, not formally tested or approved, but something to consider.
So Josh, another sort of targeted therapy question that's been in my mind is, lung cancer, I think really was the first where we saw people using systemic therapy in brain mets and holding off on radiation therapy in patients initially with EGFR, then ALK. And I'm curious right now, if you have a patient who has asymptomatic, multiple small brain mets, and what targeted situations will you go with the targeted therapy as opposed to radiation? Where do you feel most confident enough to start with targeted therapy?
Yeah, it's a great question. In a patient who's asymptomatic, no edema, not on steroids, not on any anti-epileptics, if I have a therapy that has good CNS penetration, and Sarah's one of the leaders in the CNS in our field, I will use that therapy. So, third generation EGFR TKI, osimertinib, I'll use that in the frontline setting in a patient with untreated brain mets. Alectinib, for example, in the ALK rearranged space. But, you can extrapolate this also to MET, like capmatinib, tepotinib, and others. A lot of our targeted therapies have, really good CNS penetration. And to radiate somebody up front and then deal with that radiation necrosis and other complications down the road as our patients are doing much better. We'll talk about some of the ALK and some of the ROS data. People are living 5-7 years. We do need to think about using radiation when the time is needed.
Sarah, anything you want to add to that? Any situations where you'll treat a patient with mild symptoms with systemic therapy and hold off on radiation, particularly if they need whole brain?
I will not give whole brain radiation to patients with targetable alterations because, just as Josh mentioned, for the toxicity reasons, these are patients who are very likely going to live many years. And so whole brain radiation is off the table regardless of how many metastases there are. If I feel like someone needs local therapy because of a symptomatic lesion or something in the brainstem or a concerning place, I would still consider SRS to those couple of things or one or a few things and then not treat the rest just so I can avoid whole brain radiation. I think we don't have good prospective data on this. There's retrospective studies. There's subset analyses from the big trials showing that these drugs really do have activity. So do we know that patients do better when they get systemic therapy up front instead of local therapy? We don't really know. So if a patient has symptoms, if there's a larger lesion, which I don't know the definition of that, more than a centimeter, more than 2 centimeters, there's no clear cutoff, or if it's in a concerning area where I would not want to see that grow, I probably would think about upfront radiation, again, SRS, not whole brain. But if someone has multiple or even one or a few small asymptomatic lesions, I totally agree that upfront systemic therapy with close monitoring of the brain is really reasonable.
So Josh in a second is going to talk about new data in first-line therapy, EGFR mutant disease, where we now have 3 choices. I guess, Sarah, it's been about 20 years now since we even discovered EGFR mutation. I actually interviewed the former chief there at Yale, Tom Lynch, around that time, and I said, why do you think these people are having these great responses to gefitinib? And he got like all red in the face, and he said, I can't tell you. I go, what? And then the next day he was on Good Morning America because it was embargoed, that they had discovered the EGFR mutation. So now, 20 years later, I've been asking you all for years, are you going to use it adjuvantly? You're finally using it adjuvantly. But now the first-line metastatic setting is getting pretty complicated. We just saw the approval of amivantamab, the bispecific with lazertinib, very similar to osimertinib. Before Josh gets into the data, I'm just kind of curious what happens when somebody with EGFR mutation shows up needing first-line therapy.
So you said it really well. It's been 20 years since not me, but we discovered the EGFR mutation, and the targeted therapies have evolved over time. And what we learned over all these years is many patients will do really well with a single agent EGFR TKI, and now, of course, our standard has become osimertinib based on better data compared to earlier generations. It is really nice to be able to use single agent TKI for patients because some of them are going to do very well for a long time. But now we have this study as well as the FLAURA2 study, chemotherapy plus osimertinib. Both of them are positive studies where patients are doing better, have an improvement in progression-free survival compared with single-agent TKI. So it has become very complicated, and it's no longer one-size-fits-all where everybody gets osimertinib. I think now it has to be very careful considerations of lots of different things, the patient's performance status, their wishes, high-risk features. It's really complicated, and we don't have good prospective data to tell us which of these combination regimens is best. But I think we should be thinking about these options. There still will be people where I will give single-agent osimertinib to, but these should lazertinib and amivantamab, as well as chemo and osimertinib, those are regimens that now we have as options for patients and we could consider, but how to select patients is really the big question.
Josh, again, you'll go through the data, but I'm just kind of curious how you approach it clinically. Now we may be looking at a sub-Q version of amivantamab, which hopefully will make a big difference in terms of infusion reaction, particularly for a younger patient, otherwise, healthy, who want, family, et cetera. Says, I don't care about toxicity, just give me the best therapy. How do you approach that?
Yeah, first off, I think you need to block at least an hour in your clinic for any new patient with an EGFR mutation these days. And, as a fellow, I watched the first generation, then second generation inhibitors come, then the third generation. So I think we need to advance the field for patients. I mean, we'll talk about the data for FLAURA, but 18.9 months progression-free survival is great, but it's not enough. We need better. So I think combination strategies are the way forward, but we have to mitigate toxicity. So just like Sarah does in her clinic, I have that discussion with the patient about the 3 regimens. And if a patient wants to be aggressive, they got young kids at home, they're 42 years old and they want to maximize their survival, I will go with a combination strategy in the clinic. And again, we also have to understand that not all EGFR mutations are the same. L858R patients do far worse than exon 19 del. So I do get into the nitty-gritty with patients in the office because they need to know. They need to select the best regimen for themselves.
Which combination?
So, I'm mostly enrolling on a clinical trial, so it's hard to say, but, I have a preference for amivantamab and lazertinib in the frontline setting given the data. I think OSI and chemo is easier to give, and clearly osimertinib is easier to give and easier for patients to take. But again, it's based on that discussion, based on that patient's goals in your office.
So one more quick question from the audience, Sarah. Patients who have atypical EGFR mutations, any situations where you use TKIs? And also an interesting question, do you use IOs? Because generally we don't use IOs with EGFR, but what about these atypical ones?
So the atypical mutations have been usually omitted from these big randomized trials. So we don't have as much information on them. But I think what's become very clear is lumping all the atypicals together is really not appropriate either. They're different. The most common, if you can even call it atypical, is the exon 20 insertions. That is a totally different world and I think needs its own discussion.
And we have data on that.
We do have good data on that. So the exon 20 insertions as atypicals, if you consider that atypical, I think that's more clear-cut. I think first-line chemotherapy and amivantamab is something to consider. The other atypicals, the G719, and there's a few others, those I take on a case-by-case basis. There's some pretty good studies that show osimertinib is a reasonable option, so then I kind of bucket them in with the other common EGFR mutations and think about potentially combination strategies up front. And then there's others where actually afatinib looks really reasonable as well. So I actually, whenever I see one of these atypical mutations, if I haven't seen it before or I'm not familiar with it, I dig up the data and I look at how afatinib looks, I look at how osimertinib looks, and I sometimes do consider these second-generation drugs for some of the atypicals.
Anything you want to add to that, Josh? And also this question about IOs, when do you use them in typical mutations and what about atypical?
Yeah, I think the EGFR space outside of exon 19 del and L858R, those are the activating or common mutations, has become complicated. And there's a great paper from John Haymack's group at MD Anderson where they actually look at functional classification of EGFR mutations as opposed to just exon. Exon is just a random, putting these, different mutations together. If you look at the functional classification, like Sarah mentioned, different patients with different uncommon or PAC mutations may do differently with different therapies. So we need to study this patient population better. I think for the immunotherapy question, I'm pretty strong about this, is I will not use immunotherapy in an EGFR mutant patient until I exhaust all targeted therapy options. Why? We know that immunotherapy does not work well in this patient population, but more concerning is if you give immunotherapy and then give them the correct targeted therapy in their next line or if they progress, you can cause significant immune-related adverse events, colitis, pneumonitis. So not only are you giving the patient the wrong therapy, you're preventing them from benefiting from the correct therapy. So I'm an adamant no to IO in the EGFR and ALK and other targeted populations.
But what about the atypical ones, particularly ones that theoretically don't respond? I mean, we give them first-line IO if they have a high PD-1?
Yeah, so this is where it gets really complicated. If you look at the FDA label, afatinib is the approved regimen. Afatinib's not a great drug, right? A second-generation EGFR TKI has a lot of rash, diarrhea. We have great clinical trials available where we're seeing 80% response rates to some of these, sort of next-generation EGFR inhibitors, and we'll talk about a few of them in the discussion today. So I'm hoping in the next year or two we will have approvals for these atypical or PAC mutation patient population. Key is look at the NGS report. If you've never seen that mutation before, call a friend. I do it once a week, meaning I see something, I'm like, that's an exon 20 I've never seen. Let me call Sarah. Let me call a colleague. So I think having that humility in this field is important because you're able to get the best therapy to your patient.
So patients got a high PD-1 and they've got one of these atypical mutations, still not going to use Pembro?
Even though it's an atypical mutation, it's still an EGFR mutation that is usually in never smokers, low mutation burden. So no, I think of it exactly like Josh does, where I might consider it in later lines. I'm always looking for an immune therapy trial in later lines for these patients because I would love to give my EGFR patients a chance to benefit from immune therapy, but the standards just don't really seem to work.
All right, let's go ahead and take a look at some data, Josh.
All right, let's talk about targeted therapy. Neil, thanks for having me. And so this is our outline today. We're going to talk most of the time on the EGFR space. I'll mention the FLORA trial briefly, but we'll really dig into some of the combinations. And you heard already my gist of why I think combinations are going to be important moving forward. We'll talk about FLORA 2. We'll talk about Mariposa, but then we'll also talk about some strategies to overcome resistance. We'll briefly then hit on HER2, which is an emerging biomarker, 1 to 2% of the population. We'll talk about MET, and we'll also end with the ALK rearranged space. So we all know that EGFR mutations are common. They occur in 20-25% of patients, and this is a population that does benefit from targeted therapy. The FLORA trial showed an 18.9-month PFS for osimertinib versus gefitinib and erlotinib, which is about 10 months. So how do we improve upon that? So here's the FLORA 2 trial. The FLORA 2 trial is looking at a combination of chemotherapy, carboplatin, pemetrexed, plus osimertinib versus osimertinib alone. Primary endpoint here being progression-free survival by the investigator assessed. And actually this was really exciting data to see. The osimertinib platinum pemetrexed 25.5-month median progression-free survival. So that significantly improved our baseline with osimertinib, which was at about 16.7 months. And it's important to note that, remember, EGFR exon 19 del patients do far better than L858R, and we clearly see that in FLORA, the first trial, right? Osimertinib alone in the L858R population, as low as a 14-month median progression-free survival, whereas exon 19 del as high as about 22 months. This narrows that gap. When you add chemotherapy, you narrow that gap for that difference between the different mutations. What about the overall survival, right? There's a lot of controversy. If you use osimertinib in the front line and chemo in the second line setting, aren't you just sequencing those therapies? Won't the survival be the same? If you use them together in the front line, what does survival look like? And I think that's critical in order for us to really be utilizing this in our clinical practice. So there is a trend towards positivity here. Hazard ratio most updated, 0.75, but you do see that the curves cross at about 15, 16 months, and they are starting to move together. So this data is still immature, about 41% maturity. But what I think is really interesting is if you look at the osimertinib control arm here, 36.7 months. This is exactly what we saw on FLORA at 38.6 months. So where can we go with osi plus chemotherapy? I'm hoping we see a survival in that 40-month range. If it's similar to osi monotherapy, because patients then got chemo in the next line, maybe this isn't a major advance for our patients. More recently, we've seen amivantamab. It's an EGFR MET bispecific antibody, has unique mechanism of action. It can block ligand activation in the cell membrane. It could also have receptor internalization, degradation by this interesting pathway called trogocytosis or cellular gnawing. And then it has an immune-mediated type activity, antibody-dependent cellular trogocytosis, as well as antibody-dependent cellular cytotoxicity. So this is a drug with multiple potential mechanisms of action. In the Mariposa trial, we combined amivantamab, EGFR and MET bispecific with lazertinib. Lazertinib is a third-generation EGFR TKI, very similar to osimertinib. This was an interestingly designed trial. It was a 3-arm trial, 1,000 patients enrolled, 2-2-1 randomization. So amivantamab plus lazertinib versus osimertinib, that's the true study. And then the FDA required a control arm of lazertinib alone for contribution of component. Primary endpoint here being progression-free survival, and what you can see was an impressive improvement in progression-free survival. 23.7 months for the treatment arm, ami-laz, versus 16.6 for osimertinib. And remember, this lines up with what we've seen in FLORA and now FLORA-2 for the control arm of osimertinib. So we are consistently beating osimertinib with combinations. Same thing it holds here. What about the overall survival, right? So overall survival, also immature. We saw some updated data at World Conference Lung Cancer, but hazard ratio trending positive 0.77. And at 3 years, 36 months, ami-laz, 61% of patients alive versus osimertinib alone, 53%. What I took away and I thought was really exciting, and I have to hit on it here, is the intracranial progression-free survival. It was about 38 months for patients with ami-laz versus osimertinib, where it was 38% versus about 16%. So we're progression-free at the cut. So telling us that there's a 3-fold improvement in intracranial sort of activity for the ami-laz versus osi alone. And I do have to comment that osi plus chemotherapy also has interesting CNS penetration. Again, another sort of note here for why combination strategies may be better for our patients with EGFR mutant lung cancer. What are the toxicities? We know that combinations here have increased toxicity. One of them for amivantamab is the infusion-related reaction. So we're looking at a subcutaneous formulation of ami over the IV formulation. And this is an interesting trial recently presented where we compared subcutaneous to the intravenous. And the primary endpoint here was a PK or pharmacokinetic sort of value, this endpoint of C trough at cycle 2, day 1. Are these equivalent biologically? And what we saw is they are. In a randomized trial of over 400 patients, it seemed to be equivalent. But what was interesting is in this subcutaneous formulation, and this is not a primary endpoint, it was an exploratory endpoint, we saw actually a benefit in overall survival. So there is a phase 3 study underway now, the Copernicus trial, looking at amivantamab sub-Q plus lazertinib versus osimertinib in the front line. We know that acquired resistance is inevitable, right? So this is acquired resistance here to third-generation EGFR TKI, but we're starting to see acquired resistance emerge to osimertinib and chemo, as well as amivantamab and lazertinib. And we know that there are on-target mutations like C797S, there are bypass tracks like MET amplification, for example, and then there are patients who have histologic transformation. So rebiopsying patients is critical, and 50 to 60% of patients do not have a resistance mechanism identified. So how do we capitalize on these resistance mechanisms? Historically, we've built 4th-generation inhibitors. Here we're looking at data targeting C797S with older compounds like Blue 701 or Blue 945 that are no longer in development, but we were able to see responses, but they were not robust and not durable. So we're no longer moving forward with that study. Other strategies are to look at individual resistance mechanisms and to add a targeted therapy. So if you have MET-mediated resistance, add a MET TKI. So we're doing that with savolitinib. We're also doing that with tepotinib and other studies. If a patient has a resistance mechanism with ALK or RET, adding those respective TKI to the osimertinib. And that's an ongoing study right now. Again, the data does not look that promising. Why? Because resistance is heterogeneous. So how do we think more broadly? We mentioned amivantamab earlier. There is an FDA approval of amivantamab and chemo, MARIPOSA-2, in the second-line setting. But here's a novel strategy using patritumab deruxtecan, a HER3 ADC. We know that HER3 is overexpressed in EGFR mutant lung cancer. You see the antibody drug conjugate here. And this is the data, the updated data we saw from Helena Yu at Memorial Sloan Kettering in the second or later line setting, 30% response rate, median PFS of 5.5 months. Look at these numbers compared to what we just talked about in the front line. So it's important that we move therapies that are successful into the front line setting for patients. Here we saw a press release for patritumab deruxtecan beat out chemotherapy in the second-line setting in EGFR mutant lung patients in the HERTHENA-Lung02 study. So we look forward to seeing hopefully an approval based on this data shortly. Switching gears from EGFR, let's jump into HER2. HER2 is an uncommon mutation, HER2 exon 20 insertions, about 1 to 2%. But don't confuse HER2 overexpression, which is what you see in breast cancer, with HER2 gene mutation. Or don't confuse HER2 amplification with HER2 gene mutation. We're specifically talking about HER2 gene mutation here. So ADC trastuzumab deruxtecan, also with an accelerated approval in the second-line setting based on the DESTINY-Lung01 55% response rate, progression-free survival here in the 9-month range. A very exciting therapeutic option for patients. However, we do see increased toxicities with ADCs, particularly the hematologic toxicities. We can also see some pneumonitis, which I think we need to watch for very closely. And one important thing on this DESTINY-Lung01 study is biomarkers are important, right? When we looked at HER2 overexpression, we did not see as robust response rates in that 20% range. We have now looked at a broad study of all HER2 mutant patients, or HER2 overexpressed patients, I should say, and we do now have an FDA-approved label for 3+, but I think the data is somewhat shaky, and you should really think about other options for patients with lung cancer who are HER2 overexpressed. We'll wrap up with MET alterations as well as ALK. MET alterations are common, 3 to 5% of patients, MET exon 14 being the most common, but you also have rare MET fusion as well as MET amplification, which we mentioned already. The Profile 1001 study is crizotinib, 32% response rate, so not really an effective targeted therapy strategy. More recently, we've seen the Geometry Mono 1 of capmatinib, where you're seeing more robust activity as well as intracranial activity in that 50+% range. This led to an FDA approval, as well as the Vision trial with tepotinib, where you see response rates in treatment naive about 57%, also intracranial response rates greater than 50%. So 2 FDA-approved therapies, major toxicities here being lower extremity edema. This is a MET-mediated toxicity that we see across all agents.
Any way to separate the two, Sarah? Is it coin flip or any difference in toxicity, efficacy?
I think it's a coin flip to me. I sometimes will try, if someone has toxicity with one, I might try the other, but I haven't seen so much of a difference clinically.
All right, let's talk about ALK.
Yeah, I think this is probably the most interesting and exciting data we saw at ASCO in the lung cancer space. We saw the 5-year update for the CROWN trial. So ALK rearrangement, relatively uncommon, maybe 3-4% of the lung cancer population. And we have 3 FDA-approved regimens. We have alectinib, we have lorlatinib, and we have brigatinib. And remember, these were all studied versus crizotinib. I just pulled out the CROWN trial here due to time, but lorlatinib versus crizotinib, if you look at the 5-year update for progression-free survival, patients are, we haven't met median yet, right? So 63+% of patients are progression-free at 5 years. And that's quite impressive. When you look at the intracranial progression-free survival, hazard ratio here is 0.8. We have never seen data like this in clinic. So this is an exciting time in the targeted therapy space, and I'll end there.
So a couple quick questions from the audience. Sarah, Dr. Safar, who's here as a 55-year-old, we talk about being ahead of time, as a 55-year-old woman who's been on lorlatinib for 3 years already, and we just saw the CROWN data, so impressive. But now the patient has progressive disease in the brain, lymphangitic spread, high O2 required with a malignant effusion on lorlatinib. Still has the ALK fusion, chemo or any other TKIs, any trials. Sounds like a difficult situation.
Yeah, so lorlatinib is absolutely amazing. The results were so exciting. I think actually the 5-year PFS is the best we've seen in any metastatic lung cancer trial ever. So it's really amazing. But this, of course, happens, right? Like patients progress typically, and even after many years. And in these young patients, it's never long enough, right? 5 years is absolutely amazing, but still 5 years in a 30 or 40-year-old is way too short. Anyone is too short. So standard is chemotherapy, right? And actually, I've had some amazing success in my patients with platinum pemetrexed, with patients with ALK fusion. So sometimes that can be incredibly beneficial. I will try to look for mechanisms of resistance. Sometimes patients can have point mutations in ALK where you could think about another TKI or there's a clinical trial. But I think in practice, typically, it's chemotherapy.
Yeah, that's a good point, though, about pemetrexed. Final question from the audience. Josh, we didn't talk about adjuvant therapy, but now we have ALK, of course. 65-year-old patient, upstage from a 2 to 3A at surgery. Does she need to give, it's got ALK, going to get alectinib. Does the patient need to receive chemo?
Yeah, I would give chemotherapy here. The ALINA trial did not. It randomized patients post-resection to alectinib versus, standard or placebo, right? I mean, no therapy there. So I would give chemotherapy prior to giving alectinib. We know that chemotherapy has data for cure in the adjuvant setting, whereas alectinib is a TKI, and do TKIs cure is a major question.
All right, we're going to move on and talk about lymphoma. Thank you so much.